All right, well, good morning, everyone. I'm Sue Uran. I am the Executive Vice President and Chief Program Officer here at Pew, where we have a diverse mix of initiatives ranging from health, state, consumer, and environmental policy initiatives to advancing biomedical and environmental research to support for our hometown of Philadelphia. Now, I know that July, the middle of July, is prime time for leaving DC for beautiful and perhaps cooler summer places like the coast of Maine. So I am particularly pleased to welcome all of you here today and our very special guest, Senator Susan Collins from the great state of Maine. Now, we're recording this event so that it can be presented on Pew's podcast called After the Fact, which will extend the reach of Senator Collins' remarks beyond this room and beyond today. Now, before I invite Senator Collins to the podium, I wanted to spend just a minute giving a brief overview of her extraordinary career and the bipartisan effort that she is leading to stop the escalating cost of prescription drugs. Senator Collins grew up in Caribou, Maine, and graduated magna cum laude from St. Lawrence College. Within months of finishing college, she was working in the office of Senator William Cohen, also from Maine, a tenure that lasted 12 years and included working on the Government Affairs Subcommittee on the Oversight of Government Management. She also worked as the commissioner of the Department of Professional and Financial Regulation under former Maine Governor John McKernan Jr., and the regional director of the Small Business Administration for President George H.W. Bush. In 1996, Senator Collins was elected to the U.S. Senate. And in the years since, she has never missed a roll call vote. That's more than 6,600 votes in a row. Now, the people of Maine clearly trust and admire Senator Collins, and so do her Senate colleagues. For the past 4 years, she was ranked the most bipartisan member of the Senate by the Lugar Center at Georgetown University. Here at Pew, we talk a lot about the importance of public service. Senator Collins' unbroken record of constituent service and fulfilling her constitutional duties pretty much define that term. So today, Senator Collins is here to help us better understand her work to stem the out-of-control increases in prescription drug prices. She works closely with her colleagues in both parties, especially Senator Claire McCaskill of Missouri, to carefully study this issue and propose evidence-based solutions. Earlier this year, she introduced legislation to eliminate pharmacy gag rules that prevent patients from knowing the lowest possible cost for prescription drugs. And just last month, the Senate Judiciary Committee passed legislation co-sponsored by Senator Collins that will increase competition and increase the affordability of prescription drugs for all Americans. Senator Collins is a leading voice, not only for fair drug prices and better health outcomes, but for comity, civility, and generosity. So now it's my great pleasure to introduce Senator Susan Collins.
Thank you, Sue, and good morning to all of you. I'm delighted to be here to join in an important discussion, and I want to commend the Pew Charitable Trust for its extensive research work in so many areas, including your drug spending research initiative, which I'm very much looking forward to seeing the results of. I want to acknowledge Kevin Kelly of my staff, who is the staff director of the Aging Committee, but actually worked here for a while, a couple of years, in between stints in my office. And so he knows well the terrific work that the Pew Charitable Trust does. I also understand that we're either going to be joined by or have been joined by the Pew president. There she is. I see her, Rebecca Rimmel. I read all about you last night. It was really impressive, your medical background, that you were able to convince physicians to allow you to be a professor of neuroscience. Shows that not only your extraordinary ability, but persuasiveness, too, I would say. So thank you for making the effort to be with us today. Today, I'm going to discuss the work that I've been doing at the federal level to combat the rising cost of prescription drugs to ensure that patients have affordable access to the therapies that they need. With prescription drugs being identified in virtually every study as one of the key cost drivers for healthcare, it is essential that we better understand the underlying causes of soaring prices so that we can develop and implement policies that both encourage innovation and the development of new drugs while protecting consumers from escalation that has no justification. The past century could well be called the age of miracle drugs, from insulin to penicillin to pharmaceuticals that treat cancer, HIV, heart disease, and so many serious health conditions. Modern drugs improve, extend, and even save lives. In our time, however, we might define a miracle drug as one that has not doubled in price since the last refill. Over the weekend, the Wall Street Journal reported 3,653 price increases on a little more than 1,000 different drugs since the beginning of this year. Some of the price increases were modest. Others undoubtedly were justified. But in the case of a spray version of a common sleeping aid, the price soared from $69.88 to $659. And it is very difficult when you read this article, we haven't investigated the specifics yet, but to see any justification for that kind of price spike. The issue, after all, is about people. It's about patients who need required medications. It's about their family members and their friends and neighbors who are worried about their struggle to buy the medications that they need. This was brought home to me in a very real way recently when I was standing in line in the pharmacy in Bangor, Maine, where I live. And I was right behind a couple, and I wasn't meaning to eavesdrop, but their raised voices made it impossible for me not to hear their conversation with the pharmacist. Their copay was $111. And the husband turned to his wife and said, "There is no way that we can afford this." And they just turned around and left the drug there. And I was so troubled by seeing that, because obviously this drug had been prescribed for them, so it was something that they needed, that one of them needed. So I queried the pharmacist about how often this happened. And imagine my dismay when his response was, "It happens every day." So the cost of these vital drugs is not just a theoretical concept or an interesting research project. It has a real impact on individuals, healthcare systems, and the federal government. Americans spend a staggering $328 billion on prescription drugs each year. The federal government picks up about $129 billion of that in payments through Medicare, Medicaid, the Veterans Affairs, CHIP program, and other programs. So in November of 2015, alarmed by these price increases, as chairman of the Senate Aging Committee, along with then-ranking member Claire McCaskill, I launched an extensive bipartisan investigation into the extreme spikes that we were seeing in drugs that had been off patent. In other words, their patent had expired, and yet they did not have a generic equivalent. The drugs that we examined ranged from nitropress, which is used to treat dangerous cardiac conditions, and is often found as a standard drug on hospital crash carts, to drugs used to treat rare genetic diseases, severe infections such as tuberculosis, and other life-threatening conditions. The findings of our investigation were troubling, to say the least. At our first hearing in December of 2015, we centered on 4 companies that had acquired decades-old, off-patent, affordable drugs and then raised their prices suddenly and astronomically so that they were no longer affordable. I remember that one of the drugs had first been entered the marketplace the year after I had been born. It was 1953 that it first became available. It had been off patent for many, many years and stably priced for many, many years. The investigation uncovered a monopoly business model that these companies use for selecting life-saving prescription drugs. For example, the price of a Valiant drug that is used to treat Wilson's disease, a rare genetic disorder that is fatal if left untreated, increased from $652 per month to more than $21,000 per month. That's more than a 3,000% increase in price with no justification. Our committee staff interviewed hundreds of patients, doctors, hospital administrators, other healthcare providers, consumer advocates, academic experts, and pharmaceutical industry executives and their board members. We reviewed more than 1 million pages of documents, many of which we subpoenaed, obtained from these 4 companies, and we deposed or took transcribed interviews of 10 corporate witnesses. We held 3 public hearings and issued our report with our findings and recommendations. Regrettably, we issued that report in December of an election year, and it really didn't get the attention that it deserved. But its findings and recommendations remain valid and remain a source that we are working on. One of Pew's State Line articles on drug pricing featured a photograph of Martin Shkreli. That was taken during his testimony before Congress. His truly is the face of this egregious business practice, as he formerly headed 2 of the companies we examined, Turing and Retrovin. Today, Mr. Shkreli won't be found at any fancy corporate headquarters, but instead among the inmate population at the Fort Dix Federal Prison, where he's serving 7 years for securities fraud. But I was struck by an interview that he gave in which he was asked, well, why did you raise the prices of these drugs so exorbitantly? And he answered simply, because I could. The committee discovered that each of the 4 companies that we closely examined followed a business model that gave them de facto monopoly pricing power, enabling them to impose and protect astronomical price increases. The business model consists of 5 central elements. First, the companies would look for a sole source drug, for which there was only one manufacturer and therefore would face no immediate competition, maintaining complete power over its pricing. Second, the company would ensure that the drug was considered the gold standard, the best drug available for the condition that it treats. Third, the company would select a drug that serves a small patient market. And this was because they figured that these patients would not be able to organize effective opposition. They also calculated that if the patient pool were small, it was unlikely to be that attractive to generic competitors. And that gave the companies more latitude to hike their prices. Fourth, the company would control access to the drug through a closed distribution system, a specialty pharmacy, or some other means, making it more difficult for competitors to obtain a sufficient amount of the drug to do the bioequivalency tests that the FDA requires to enter the market. And finally, then the company would price gouge, maximizing profits by jacking up the prices as high as possible. Now, I want to stress that each of the drugs that we investigated had been off patent for decades. And here's another really important fact. None of the 4 acquiring companies had invested a single penny in the research and development of these drugs. Furthermore, the committee found that they were doing nothing to significantly improve the drugs that would justify the exorbitant price increase. There were no increases in production or distribution costs that would justify the cost increases. Here are just a few examples of the business model in action. Turing, which at one point was run by Martin Shkreli, raised the price of Daraprim, the gold standard for toxoplasmosis, from $13.50 a pill to $750, literally overnight. Then they put the drug in a closed distribution system. Now, these closed distribution systems, one example of which is the REMS system, is intended for drugs that have serious side effects. So you want to make really sure that the distribution is carefully controlled. It is not intended to prevent a generic drug company or some other competitor from buying up enough of the drug to do those bioequivalency tests that I mentioned earlier. Here's another example. Retrophin raised the drug price that is the preferred therapy for a rare chronic genetic kidney disease from $1.50 a tablet to $30 per tablet, and once again instituted a closed distribution system. I could go on and on. Let me give you one more example. Rodalis raised the price of a drug that is the gold standard for a multi-drug resistant kind of tuberculosis from $500 for 30 capsules to $10,800 for those same 30 capsules. I don't know how these companies can live with themselves, I must say. Valiant, the largest of the companies that we investigated, presented the most complex case. This company spiked the price of not one off-patent gold standard drug, but 4. It raised the price of 2 hospital drugs that are life-saving in emergency cases of cardiac arrest. The business model employed by these 4 companies was also actively supported and promoted by investors on their boards. All 4 companies had close relationships with activist investors who were intimately involved in the direction of the companies. We got a lot of emails that were back and forth. In the case of Retrovent, internal emails revealed how an investor outlined the business model to then CEO Martin Shkreli, writing, quote, "Funny that these small companies still haven't realized that you can raise the price aggressively and nobody gets too upset. This dynamic may not last forever. You need to maximize the opportunities while you can." Well, sudden price spikes in decades-old drugs have devastated patients and families throughout our nation. Dozens of people called the company to share their personal stories. People have been forced to go without vital medicine or to use less effective drugs. People are skipping doses or hoarding pills out of fear that their next refill will not arrive or will be unaffordable. Poignantly, patients reported the anxiety they felt as they watched the prices climb and felt so helpless to do anything about it. Hospitals, too, have been forced to make extensive changes while simultaneously facing great uncertainties and suffering budget repercussions. As much as $12 million per year more for one hospital system for those crash cart drugs that I mentioned. In an effort to reduce costs, hospitals have taken aggressive steps to reduce their usage of these drugs, even though they may be the most effective means of treating a patient. The increased time that administrators, physicians, nurses, and others who treat patients spend in developing policies and learning and implementing new protocols is time away from direct patient care. Hospitals even reported to us having to hire new full-time employees just to assist patients with administrative processes of being able to obtain medicines in the face of soaring costs. So what we started to see were rural hospitals, which were already barely hanging on, being really hurt by these drug cost increases. Our investigative work continues today. One hearing earlier this year was on rheumatoid arthritis drugs, and it revealed that medicines developed decades ago to provide relief from that painful condition have doubled in price since 2012. A hearing that we held in May on the cost of insulin provided the very definition of irony. When a team of 3 scientists at the University of Toronto discovered insulin in 1921, they revolutionized the treatment for diabetes, transforming it from a debilitating and fatal disease to a manageable chronic condition. These scientists sold the patent for $1 each to the university, a move intended to ensure that those in need would always have affordable access. They explicitly stated that that was their purpose. Their admirable intentions have been betrayed. The price for a vial of Humalog, for example, increased from $35 in 2001 to $234 in 2015 to $275 in 2017. We had a father with a son with type 1 diabetes testify at our hearing how frantic he was to find affordable insulin for his son. He finally found that the best way for him to get it was from Canada. He lives in Maine, so he could get it from Canada. He should not have to do that. And I'm really worried, given the escalation of the cost, that we can't figure out why or get a good explanation. There have been some modifications in different kinds of insulin. Some acts more quickly, some acts more slowly. But insulin's been around since 1921. The cost increase may be due, in fact, from a practice called evergreening. And that is when pharmaceutical companies obtain new patents for drugs based on small innovations, the result of which is to extend a market monopoly on the drug beyond the initial patent's expiration. Although the small changes may make a tremendous difference for some patients, the improvements may not be worth the additional cost for some. But you know what it's like. We always want the newest, the best, what is the new thing on the market, even if it may not really be worth the additional cost. For insulin, a careful look is warranted to determine if the modifications were used just to extend the patent protections and discourage competitors. And this brings me to the important question of what can Congress do about this? Following our initial investigation, I co-authored a bipartisan bill with Senator McCaskill to promote generic competition to help lower the cost of prescription drugs. Our goal is to help foster a more competitive marketplace, and it was signed into law last year as part of an FDA reform bill. As a result of our new law, FDA is taking action and last month published an updated list of off-patent drugs that do not have an approved generic. That's a welcome dose of sunshine because it helps the competitor figure out which drugs patents have expired. That was required by our law. FDA also established a competitive generic therapy program, an incentive to create more competition for applicants for which there is no more than one approved generic. Because what we found is you generally see the price drop when there are two generics on the market, not just one. And we're beginning to see progress. Since June of 2017, FDA has approved generics for 11 drugs that were formerly sole sourced. And just last month, FDA reported that there were 16 designated abbreviated new drug applications awaiting FDA action at the end of March. And that's an increase from 3 awaiting action at the end of December 2017. But more remains to be done. The HELP Committee is the Senate Health, Education, Labor, and Pensions Committee is also delving into this issue. At a HELP Committee hearing last fall, I focused on the role of pharmacy benefit managers, also known as PBMs. After hearing from pharmacists in Maine, I learned that some contracts between PBMs and pharmacies actually contain so-called gag clauses that prohibit pharmacists from telling consumers if their prescription would cost less if they paid for it out of pocket rather than using their insurance. But they can only answer that question if the consumer asks. Well, it's so counterintuitive to think that paying out of pocket is going to be cheaper than using your insurance. Using your debit card is going to save you money over using your insurance card. Who's going to think to ask that? So I was outraged when I learned about this process, and I was so grateful to these pharmacists from Maine for coming to me and telling me about it. I have to ask a basic question as well, and that is, how can it be that an insurance company's prescription benefit manager, whose very job it is to negotiate lower prices, drug prices, could instead be leading consumers to pay more for a drug than they otherwise would have to? Now, due to the publicity, a lot of PBMs have dropped these, and Seema Verma, the head of CMS, has also sent out a letter saying that they are no longer acceptable. But we want this to be law, and we've introduced two bills, one that will go to finance and apply to Medicare and Medicaid programs, one to the Health Committee that will apply to the Affordable Care Act programs, to ERISA programs, private health care programs, to make sure that this pernicious practice is ended once and for all. A common thread in all of our investigations and hearings is a lack of transparency in the pharmaceutical system. What we have noticed is that price varies on a number of factors. It includes the list price set by the manufacturer, the fees charged by distributors, wholesalers, and other middlemen such as the PBMs. And a lot of times the negotiated price is not passed on to the consumer. Sometimes it's used to lower premiums. That may be a good thing in some cases. But a lot of times the consumer is not seeing the result of the impact of those negotiations. We also found that these overlapping relationships have created a system that's rife with conflicts of interest and perverse incentives. For example, if you're a PBM and you're controlling which drugs are listed on an insurer's formulary, the manufacturer has a perverse incentive to have a higher list price, because then the PBM, who's often paid on a percentage basis, is going to get more for its work, and the manufacturer wants that drug included on the formulary. So it seems to me there's an inbuilt conflict of interest right there, although, to be fair, we're still investigating this. When we did our hearing on insulin, the American Diabetes Association, which had spent a great deal of time studying the cost of insulin and why it had increased, gave us a chart, and it is unbelievably complex. And when we asked them to explain it, they essentially threw up their hands, despite the extraordinary research that they have done. That's how opaque the system is. Healthcare is complex enough for consumers to navigate without the added confusion of a drug system that is so opaque. I will say that I have raised these issues at hearings and in conversations with the FDA Commissioner, Scott Gottlieb, and I am very impressed with him. He agrees that the current system is too complex, it is opaque, and at times it seems to be designed to benefit everyone except the patient. The commissioner is especially passionate about redesigning the rebate structure to ensure that savings are passed on to those who need them most, patients and their families. He's announced that the FDA will expedite generic entry for cases with the limited competition, and he has stated his commitment to increasing competition overall, which is very encouraging. I'm also encouraged that in Congress, at a time when bipartisanship seems like an increasingly rare commodity, that this is an issue that can bring us together. While the lion's share of work remains to be done, the multitude of hearings, letters, bills, and milestones so far demonstrate a pattern of working together and across the aisle to help reduce the cost of prescription drugs. If we want new medicines to reach consumers who need them, the companies that invest in R&D must see a fair return on their investment, and I recognize that. At the same time, we cannot allow price manipulation to continue at the expense of some of the most vulnerable Americans and their families, and ultimately at the expense of the American taxpayer. The required policy solutions won't come in the form of a miracle, but with hard work to better understand precisely what is happening and continued bipartisan cooperation. I want to thank you for being part of this effort, and it's something that matters greatly to me. We're going to continue working on it in the Aging Committee and in the Health Committee and try to continue to work on solutions to a very complex problem. Thank you, and I'd be happy to answer or to try to answer your questions. Thank you. Did I stay in my 5 minutes?
Oh, thank you. Good morning, Senator. Thank you so much. I'm Lucy Getman with Women in Government. I work with women state legislators around the country, and I'm just wondering if you have thoughts on how federal legislative leaders and state legislative leaders can work together on this issue.
I do have thoughts on how we can work with our state counterparts, and that's a very important question because having spent 5 years overseeing the Bureau of Insurance, I'm very much aware that insurance is still largely state regulated. That changed with the Affordable Care Act, but the state bureaus of insurance play a critical role. So pharmacy gag clauses are a perfect example of where some states have already started acting to ban them. Another area is innovation that states are doing with the Medicaid program to do more price negotiation. I think there are some 16 states that are using one particular company to do negotiations and select drugs for the formulary. I will tell you that I get an awful lot of complaints from physicians, nurse practitioners, physician assistants who have prescribing ability about how difficult it is to get drugs that are not on an insurer's formulary and yet are needed by their patient, and that it can take hours of their time to get an exception. And that's one reason, by the way, if you look at cost drivers for healthcare costs, administration is one of the cost drivers. So I do think there's more that we can learn from what states are doing in this area, incentives that they're using in their Medicaid programs, as well as work to ban gag clauses. There's also an interesting law that is just going into effect in the state of Maine, and it applies more to procedures than to prescription drugs, but the idea has a gem of possibility in it. And that is, it says that if you can find a healthcare provider that can do a knee replacement, for example, at a far lower cost than would be covered by your insurer, that you split the savings with the insurance company. Now, I don't believe the law has gone into effect yet, so we don't know the results. But the states, as has often been said, are the laboratory of innovation, and I think we can learn a lot from them. Yes.
Carl Polzer, I'm a longtime health policy analyst. Thanks so much for your comments and all your work. A couple questions. One, you started off with blatant description of antitrust violations and monopoly pricing and price gouging, and what can be done more on that front with the Federal Trade Commission. The other thing is on drug pricing transparency. It just seems like this is the only market because of this rebate system where we don't know what the prices are. Shouldn't there be a law that says that they have to be at least posted after the fact at some point so we can have a market?
Two great questions. I don't think the FTC has done a good job on this at all. I remember when Dr. Janet Woodcock was at the FDA, maybe she still is, and her testifying and my asking about this issue or the issue coming up. And she talked about the number of referrals that the FDA had done to the FTC, and basically very little, if anything, had happened. So I don't know whether this is a matter of inadequate resources at the FTC or inadequate expertise, but clearly this is something that we need to look into. And we also, and I agree with you, I think that it raises real antitrust questions, and it is the FTC as well as the Justice Department, but it's really the FTC that's the lead on this. And I think we need to figure out why they aren't doing more and rectify that problem. It also, though, calls out for looking at our patent laws. I think I am definitely for having a period of exclusivity, because if you develop a blockbuster drug and you've invested literally hundreds of millions, even $1 billion, you do need time to get the return on that investment. But what I'm seeing more and more is at the end of that period of exclusivity, there's a change in packaging, for example, so that the eye drop, instead of coming in daily packaging, now is a little bottle that gives you a week's supply. So I am very dubious about whether that deserves the kind of exclusivity that the initial drug development does deserve, in my opinion. That's the evergreening issue that I was talking about. So to get to your second question about the opaqueness and the rebate system, I have a theory about these consumer rebates, and that is that they are largely intended to keep the patient using that drug. And I don't want to name a specific drug because there are many, but I had a specific drug prescribed for me that I really didn't think worked very well. And then I learned that there was a rebate available, which is not available under Medicare, by the way, under the Anti-Kickback Act, and that's significant. Well, if the copay's free to you, then might as well stay on it, even though it's very expensive. That's not a good situation. It sounds like it's good because we want to help patients, but in fact, it keeps the price high. So, and it's part of the opaqueness of who's paying what and how much does the drug really cost. I've had pharmaceutical companies come in and show me their list price versus their net price, and I don't understand it because I've seen these huge increases in the price. So who's getting the money? Where's the money going? It's the classic follow the money. It really is. And we do need more disclosure of prices. One idea that's been introduced as a bill is on television ads to list the price. But what's the price? I don't know how you'd figure out what price to list. So we've got to figure out a better way to end this opaque system and figure out what the real cost is. Otherwise, it's going to be like those side effects that are listed on those, which you tune out instantly, especially if they start mentioning death, And I'm afraid that there would be the price for 30 days supply is $250, except different prices may apply in cases of rebates or depending on your formulary or depending on your insurer, depending on whether you're on Medicare or Medicaid. I'm not convinced that's the answer, but we do need to address that. You're absolutely right. The other issue that's related to this is efficacy. And I've often wished on some of these ads on television that there not only were a way to talk about the price, but how many patients does it really work for? There's one particular drug that I know has a 12% efficacy rate. Now, I wonder if that were known, if people would be running to their prescriber and asking for it. When I ran into my prescriber and asked for it, she told me it had a 12% efficacy rate, and we both said, forget it, given the cost. So I think we need way more information throughout the system. But let me just end, because I'm getting the time's up sign, by saying we really need your help. There are a lot of experts here at Pew, but also in this room. And we really need your help to figure this out. It is so obscure and opaque, and yet it has such a tremendous impact on our healthcare system and on our healthcare providers, and most of all, on patients and our family. I still can't get out of my mind, and I hope I never do, that couple in front of me at the pharmacy that couldn't afford the $111 copay and walked away from medicine that they needed. I can't get out of my mind the librarian who testified before us, who had Wilson's disease and was switched to a less effective drug because she simply could not afford the copay. I can't get out of my mind the father from Maine with the child with type 1 diabetes who was in an utter panic about how he was going to be able to afford his son's insulin. We have to come up with solutions. And with the help of people in this room, I think we can. Thank you so much. Thank you. Thank you.
So I just want to thank everyone again for coming today, and thanks Senator Collins for a fabulous speech. Thanks, everybody.